Thank you, Dr. Call, and thank you, Dr. Kachami, for the invitation today. I do have to talk to you later, Dr. Kachami. I feel like being positioned after Dr. Call and after Hannah was a little unfair. That's okay.
You're phenomenal.
I am really honored to be here today. First of all, to be in the room and be a part of this conference and these discussions, and certainly to have the opportunity to speak to everybody here today. And so this is a topic that's very near and dear to my heart. I only have 20 minutes and I have a lot to say. So what I really want to do is talk just really briefly about what is the history of APPs and where have we gone in the last 60 years? What does it look like to be a part of a multidisciplinary team? And how do we take what an APP is and have them work to the top of their license so that everybody in that healthcare team is performing maximally? We'll talk about some strategies for that, and I can't talk about best practices without acknowledging some of our challenges that all of us together need to work to overcome. And so very briefly, advanced practice provider is an umbrella term. Just in case anybody is not aware, it does include our certified nurse specialists, our CRNAs. For the purpose of today's talk, I'm really referring to nurse practitioners and physician assistants. This is Dr. Loretta Ford. She was a nurse. In 1965, she partnered with a physician, Dr. Silver, and she developed the first nurse practitioner program. In 1972, she moved to the University of Rochester Medical Center, where I work. And not only did she develop our School of Nursing there, she became Dean of Nursing at the university, and she went on to become the Clinical Director of Nursing for all of Strong Memorial Hospital. In her time, she built this nurse practitioner program because she identified that there was a need. There's a lapse of primary care providers. There was a huge healthcare gap, and we weren't able to take care of patients. She built it on a unification model. And in that model, she said, not only should we be in front of our patients, but we also should be teaching. We should be educating. And we should be looking at opportunities for innovation and for research. And that was 60 years ago. She passed away in January of 2025 at the age of 104, still advocating for nurse practitioners. And this is Dr. Eugene Steed. He was at Duke University in 1965, and he developed the first PA program. He selected 4 Navy corpsmen who had considerable experience working for military. And he looked at how do we train our Navy corpsmen? How did we do it in World War II? They needed to have that enhanced training. It had to be as quick as it could. How do we do it? And he developed the PA program. So when people say physician assistants get medical school in half the time, it was because of him. Because he said, this is our need. We have to quickly train providers. So why do I tell you this? Well, where are we 60 years later? In the 1960s, we identified we had this huge healthcare gap. And now we developed these programs, we had nurse practitioners, we have PAs. If we go right now, and I had to write this down, I had to look it up. We have 385,000 licensed NPs in the US today. We have 178,000 PAs. But look at what we're facing. Very similar. We are again facing healthcare shortage. And we're seeing it for 2 different reasons though. We're seeing we have more patients, right? We have an aging population, we have a higher demand for really complex diseases. That's why we're all here. And we're also seeing there's new procedures, there's new medications, there's new techniques, and there's this need for subspecialization. And then we have the physician shortage. And that's really accelerated in the last 5 years since COVID, as we all know, but also we have an aging physician population. And we have this evolving healthcare landscape, which we've talked about a lot over the last day and a half. And so we have this growing patient population, this high medical complexity, we have this need for value-based care, and we have technology and AI and health equity concerns, and we have sustainability and cost concerns, and we have all these policy and these regulatory changes, and we have this great need. And so with all of this, that need for that subspecialty education and that service has increased. Healthcare teams now provide care in a multidisciplinary fashion. That didn't happen as much 60 years ago, right? So we're in a very different setting, and that's where this role of the modern APP comes from. This is a paper Dr. Call and I published recently, and it's really about the GI APP, but a lot of these tenets can be applied to any other discipline. It's team-based care. It's comprehensive patient management and quality improvement. It's an eye for patient outcomes. It's looking at independent collaborative practice models and that continuing education and professional development. This is some of our GI APP team. We are fortunate to have 25 APPs who all have a subspecialty in GI as well. And if anybody's looking for a resource, this is excellent. This is from ASCO 2023. They have a whole handbook, and I just pulled a piece of it, but it really is talking about what's the impact of APPs in oncology. And so if I take that broader, and a lot of this I'm trying to take at GI, surgery, oncology. If we take a step back and say, what's that role of APPs? Obviously, patient-facing is at the forefront. Patient evaluation, diagnostic workup, but it's also that peri-procedure, peri-surgery workup. How do we communicate with cardiology, with pulmonary? How do we make sure our patients are in the best shape that they can be? We're ordering systemic therapies, we're monitoring, we're treating complications, sometimes procedures. There's definitely an emphasis on survivorship, long-term care, advocacy, education, family support, clinical trials, and that multidisciplinary team. And so when we talk about how do we incorporate APPs and what's really the benefit, my role is 50-50. I am 50% clinical, 50% administrative, so there's always a business ROI. I'm learning this. On the clinical side, it's obvious, right? We're focused on the patient. We want to improve patient care, and to me that means we have some continuity of care, we have patient satisfaction, we have positive patient outcomes, we have good workflows. On the business side, it's really cost efficiency. So we have less hospital admissions, we have less length of stay, optimized resources, more revenue. Dr. Gawande said the key to success in healthcare is the same as any other system, working together as a team. This is a handout that we utilize, and it goes to every patient before their new patient visit, and it really just tells them, you're gonna see a team. There is a physician that's assigned to you, but you may see an NP or a PA or a nurse or multiple other people along the way, and we are all a team. When we talk about team, we can have little teams and really big teams. So a multidisciplinary GI oncology team to me means all of these people and probably more. And within that team, we also have to acknowledge that that means it's the physicians, it's the APPs, it's your nurses, it's your genetic counselors, it's your dietitians, your psychologists, right? We can go on and on. It's a big team. And it's really important. It's important for our patients because of those improved outcomes, because they get better access to care, because they have higher satisfaction, because now they have a team that's working with them. They have a person at all times for whatever that is. And it's better for the healthcare professionals. We have better communication when we work together. We have improved patient outcomes, which is what we're all here for. Streamlined treatment pathways is most important to have a successful multidisciplinary team, educational opportunities. So how do we do this? How do we actually optimize our advanced practice providers so that we can really maximize the impact that they can make on any of these teams? I'm going to go through just a couple of these in more detail, but I really think role clarity is one of the most important, and we have to have that from the beginning. Role clarity is going to be their scope of practice. It has to align with experience in their training. You have to be able to onboard and integrate anybody in the team into the team, and that includes our nurse colleagues. Professional development, you will hear from me multiple times. That is a huge thing for not only career growth, but also for retention. Effective communication and collaboration, having that open, transparent communication, having the feedback, and as much as I'd read them, having the performance reviews. You have to leverage APPs for their expertise. A lot of that comes from education, advocacy, and support. And that team-based culture is something that really has to be worked on and fostered. And so I think of that as having an APP at the table, having them as part of these conversations, and then finally, obviously, measure your impact. Scope of practice is really important, particularly for APPs in the United States. What's important to know is scope of practice varies depending on the state and also depending on if you're a nurse practitioner or a PA. Quick, easy example, in New York State, PAs can first assist right at the school, nurse practitioners cannot. It sets the framework for how the APP can function, and it is rapidly changing. So, especially over the last 5 years, but even if we go 15 years ago, our scope of practice is very, very different. It's important to know and understand. We can't have our APPs working to the top of their license if we don't know what their scope of practice is. And that top of license practice, by definition, is that every member of the team performs routine activities that use the full extent of their education, their training, their experience, and their competency. And this is shaped by a lot of regulatory bodies. And if we talk about onboarding, it can take time. We have to give them the time. First thing, like I said, role clarity. Hire them into a position that you know that they need and what they're going to be doing. The second is really that introduction. What's the practice's missions, values, and cultures? Who's the care team? Clinical education and training tends to take the longest. It obviously starts from the beginning. It doesn't end for typically 2 years, sometimes longer. Integration into the care team, knowing what those communication strategies are. How do you contact people? Who do you contact? How do you use the electronic health system? How do you bill? And then that professional development support, which should be ongoing. And there's a lot of opportunities for professional development. The first one, clinical development, is applicable to any clinical APP, making sure that the patients that the APP is getting the education so they can see more complex patients over time, developing more skill sets, maybe doing some ancillary procedures or some other things that they're interested in. Scholarship and research for the APPs, we talked about this yesterday too, but there's a paucity of literature. If you see a really great case study, please publish it. Teach the other APP colleagues out there, teach the other providers. CME opportunities such as this, tuition benefits, some national society roles, a lot of opportunities for professional development to really engage. So what about the challenges? There's always roadblocks. The first one is really that misunderstanding of role, or not knowing the role. And when we think about this in a multidisciplinary care team setting, who's taking ownership of what? Who's doing what? How do we reduce that duplication of work? And how do we make sure there's ownership so that patients are getting what they need the most effectively? There's a lack of understanding of scope of practice. Again, it varies, and it's also rapidly changing. Underutilization is a really big one, and that comes back to scope of practice. If we know what APPs can do, then we can start to leverage them for what they can do. And I can give an example of that too, right? So I started, I'm gonna date myself, 17, 18 years ago. When I interviewed, I started out in solid organ transplant. I sat in front of the physician and he said, I've never worked with a PA. Tell me why I should hire you. What can you do? And we had to have that conversation. We now have over 800 PAs in the institution, almost 2,000 APPs total in the institution. Rapid growth. And what we could do when I started 18 years ago and what we can do now, it does look different because the needs are different, because the advocacy's been there. There's resource limitations, and oftentimes there's a lack of structured support, and I think that comes along with that rapid growth. When we started, when there were only 5 PAs in the hospital, we didn't need a whole infrastructure. There were only 5 of us. Now when we look at it and there's 2,000 APPs, we have to have an APP leadership structure. And I want to emphasize this is really collaboration, it's not competition. And so this is teamwork. This is establishing shared goals. It's potentially looking at those team-based productivity metrics. If you have an APP who's in clinic and they're doing a lot of the behind-the-scenes work, then that's not revenue generating, but it's still very important to patient care. So how can we build that into our compensation models to make sure that they're getting credit for the work that they're doing? And it's mentorship, it's professional development, it's really focusing on the team and the team's growth. It's breaking down silos, open communication across the specialties, and really aiming for that integrated care. And it's leveraging everybody's expertise, and that looks different. It looks different for a new grad APP to an experienced one, and that's where we have to continue to push people to grow. It's the knowledge exchange, and if we keep that patient-centered in all of this, everybody's going to benefit. So where do I think we're going in the GI oncology space as APPs? I foresee we're going to continue to have this expanding scope of practice. I think it will lean more towards autonomy. There'll be more collaboration with our physicians and collaboration with the multidisciplinary teams. I think that all providers, physicians and APPs, are really going to play that key role in implementing those managing the personalized treatment plans for GI cancer. I do think we're going to get more APPs in research and clinical trials. I really hope so. And that focus on survivorship. As we see those patient outcomes improve, that focus on survivorship is going to be even more important, and APPs will be at the forefront of that. So if I were to summarize, I think it's important, we all acknowledge the importance of it. Dr. Cole and Dr. Kachami acknowledged it and have us here. But what we really need to do is focus on building that effective integration, that strategic optimization, and that care team. And so prioritizing that from the outset, looking at the resource needs and the operational details to make it effective, and ongoing efforts to enhance our team collaboration. And so that's the targeted training, and it's really looking at maximizing utilization of APPs for that patient care. Thank you.